So thyroid nodule guidelines as per the American Thyroid Association guidelines. So a thyroid nodule is a discrete lesion within the thyroid gland that is radiologically distinct from the surrounding thyroid parenchyma. Non-palpable nodules which are detected on the ultrasound or other imaging are termed as incidentalomas. Generally, the nodules which are greater than 1 centimeter should be evaluated since there is a risk of clinically significant cancer. And nodules which are less than 1 centimeter may need further evaluation if there are clinical symptoms or if they are associated with lymphadenopathy. So according to this recommendation, screening people with familial follicular cell-derived DTC may lead to earlier diagnosis of thyroid cancer, but the panel cannot recommend for or against ultrasound screening, routine ultrasound screening. So whenever there is a suspicion of thyroid nodule, TSH is a important parameter that should be measured during the initial evaluation of the thyroid nodule. If the TSH is subnormal, then the thyroid scan is performed. And if the TSH is normal or elevated, then the thyroid scan should not be performed as the initial imaging. The reason being, if the TSH is low, there is high suspicion of basically nodule or any overactivity of thyroid tissue, and the hyperthyroidism is very rarely associated with cancer. So the routine measurement of thyroglobulin is not recommended, and the routine measurement of calcitonin is not also routinely recommended. If there is a focal lesion within the thyroid nodule, that is, that once FDG, if there's a focal FDG uptake within the sonographically confirmed thyroid nodule, it conveys an increased risk of thyroid cancer, and FNA should be recommended for those nodules greater than 1 centimeter. And if there is diffuse uptake of the tracer, then FNA is not required, as it is most likely because of the chronic lymphocytic thyroiditis. And thyroid sonography with survey of the cervical lymph node should be performed on all patients with known or suspected thyroid nodule. FNA is the procedure of choice in the evaluation of the thyroid nodule, whether when clinically indicated. So the recommendations are: the thyroid nodule diagnostic FNA is recommended for greater than 1 centimeter. If the nodule is greater than 1 centimeter and there are a high suspicious sonographic pattern. If the nodule is greater than 1 centimeter with intermediate suspicious sonographic pattern, greater than 1.5 centimeter with low suspicion sonographic pattern, and thyroid can also be considered with those greater than 2 centimeter, very low suspicion, like the spongiform. And in these cases, observation can also be a reasonable option. FNA is not required for the pure cystic lesion. So features with the highest specificity for the thyroid cancer are microcalcification, irregular margins, and tall shape. These are the sonographic patterns which confers highest sensitivity for the occurrence of thyroid cancer. So first of all, if there is a suspicion of thyroid nodule, then TSH should be done. If TSH is normal or elevated, then we should get the thyroid neck ultrasound. If there is a high suspicious pattern, as we discussed, then FNA should be done. Those with greater than 1 centimeter. If there's an intermediate suspicion, again, FNA is recommended at 1 centimeter. Those with a low suspicion pattern, FNA is done at 1.5 centimeter. And at very low suspicion, it should be done at 2 centimeter. And in benign pattern, FNA is not required. When the thyroid nodule is biopsied through the FNA, then if it is non-diagnostic, then the recommendation is to repeat the FNA. In case of benign, surgery, nothing is required. And in case of other indeterminate classes, we will be discussing the guidelines shortly. But however, if there is malignant, then surgery is the first option. So just to summarize, if there is malignancy, then we should do the surgery. If that is benign, no surgery is required. If that is non-diagnostic, repeat the FNA. And in between, that is the AUS, FN, and suspicious. If the thyroid Bethesda category falls under this category, then we should consider other treatment option as well. So the sonographic pattern and the estimated risk. So if that is basically the risk of malignancy, and according to the FNA aspiration guidance for the thyroid nodule. So if the sonographic pattern is benign, that is purely cystic, then the estimated risk of malignancy is less than 1% and no biopsy is required. If that is very low suspicion, then these are the nodules with spongiform, a partially cystic nodule without any of the sonographic features. So in these cases, the estimated risk of malignancy is less than 3%, and FNA is considered only if it is greater than 2 centimeter. Observation without FNA is also a reasonable option in these cases. However, if there are low suspicion sonographic pattern, that is isoechoic or hyperechoic solid nodule, a partially cystic nodule with eccentric solid areas without microcalcification, irregular margins, or extrathyroidal extension, then the risk of malignancy is 5 to 10%, and FNA is recommended at 1.5%. So in low suspicion, it is basically either isoechoic or hyperechoic solid nodule, a partially cystic nodule. If and the other category is intermediate suspicion sonographic pattern. In these cases, they would be hypoic solid nodule with smooth margin without microcalcification, ETE, and it would be taller. Risk of malignancy is 10 to 20%. FNA is done at 1 centimeter. And in high suspicion, there would be solid hypoechoic nodule or solid hypoechoic component of the partially cystic nodule with one of the following features like irregular margins, macrocalcification, taller, and rim calcification. So to differentiate between the intermediate and high suspicion, it is very important to see if there is what are the margins. If the margins are smooth, it is intermediate, and if it is if they are infiltrative margin, then it likely falls under category of high suspicion. And in case of high suspicion, the risk of malignancy is 70 to 90%. So just to make the estimated risk of malignancy simplified, in case of benign lesion, it is less than 1%. In case of very low suspicion, it is 3%. And low suspicion, 10%. And intermediate, 20%. In case of high suspicion, it is basically 70%. So then ultrasonographic features of the lymph nodes, which are predictive of the malignant involvement. If there's a microcalcification, it has got the highest reported specificity of around 100%. Cystic aspect, it is different. It contrasts to the sonographic pattern of the thyroid nodule, in which cystic aspect is been considered to be benign. But if the lymph nodes appears to be cystic, it is likely to be malignant. Likewise, peripheral vascularity is also important. Hyperechogenicity is a sign of malignancy. Is suspicious for the malignancy in lymph nodes, while hyperechogenicity was not very much associated with um, malignancy in case of thyroid nodule, and round shape. And round shape is also important. So in contrast to the thyroid nodule, in which taller shape was associated with malignancy, in the lymph node, it is the round shape which is more predictive of the thyroid malignancy. So the Bethesda system for the reporting thyroid cystopathology are, first of all, it's non-diagnostic, and the risk of malignancy is less than 5%. And in case of benign, the estimated risk of malignancy is 0 to 3%. ATP of undetermined significance, AUS, it is the risk of malignancy is around 15%. And in case of follicular neoplasm or suspicious for the follicular neoplasm, the risk of malignancy is 30%. In suspicion of malignancy, it is around 60% malignancy risk. In case of malignant diagnostic category, it is 90%. So just to summarize and to simplify it, you should remember the figure of 90, 60, 30, 15, and 7.5. So basically 90% is associated with malignant lesion. There's 60% risk of malignancy in suspicious lesion. There's a 30% risk of malignancy in follicular neoplasm, and 50% with AUS, and around 7 to 7.5 in non-diagnostic. So in case of non-diagnostic cytology, when we should repeat the FNA in 3 months, and again, if it is non-diagnostic, then we have two options. Either we should observe these patients very closely, or if there's a high suspicion on the repeat ultrasound, or if there's a growth of around 20% in 2 dimension, then we should consider surgery in these patients. Likewise, monitoring should be done as according to the FNA. If after 2 FNA, if we do 2 FNA and those are non-diagnostic, then we should see the size of the lesion as well as size of the lesion. If the size is between 1 to 2 centimeter, then yearly ultrasound is indicated. However, if the size is greater than 2 centimeter, then it should be repeated 6 monthly. So in case of benign cytology, no diagnostic studies or treatment is required. And in case of malignant cytology, surgery is the first line option. Surveillance can be considered as alternative to surgery in few conditions. Like if patients with a very low risk tumors like papillary microcarcinoma without clinically evident metastasis or local invasion, or no convincing cytological evidence of aggressive cytology. So microcarcinoma is one thing where we can wait before going to the surgery. The other one is if there are increased comorbidities in the patient, which puts the patient at a high risk related to the surgery, and if there's a short lifespan. Since the microcarcinoma is treated around 1 to 2% of the malignancy in these patients, so it might be wise to just monitor these patients without actually going under the surgery. So then there are certain molecular testing like BRAF mutation. BRAF is important in deciding whether to go for the surgery or to wait for the expected management. The important point is that BRAF is something that cannot predict the clinical outcourse. It is something specific but not very sensitive. So if the BRAF is positive, then it is something that it may predict that then there would be increased chance of lymph node metastasis. And those patients where the BRAF mutation is positive, then there is around up to 70% risk that the lymph nodes would be involved in the coming months. So if the BRAF is negative, and then we can opt for the surveillance program. However, if the BRAF is also positive along with the ATP of undetermined significance, then we can proceed with the surgery as we have as the BRAF uh, basically supports the diagnosis towards high risk of malignancy. So if molecular testing is being considered, it should be the patient should be counseled regarding the potential benefits and limitation of testing and about the possible uncertainties and the therapeutic and long-term implications of the results. So for nodules with AUS or flash cytology, after consideration of the worrisome clinical and sonographic features, investigations such as repeat FNA molecular testing may be used to supplement malignancy risk assessment instead of proceeding directly with the strategy of either surveillance or diagnostic surgery. If the repeat FNA cytology, molecular testing, or both are not performed or inconclusive, either surveillance or diagnostic surgical excision may be performed for the ATP of undetermined significance, depending on the clinical risk factors, sonographic pattern, and patient preference. So whenever there is non-diagnostic and non-diagnostic, or if there is ATP of undetermined significance, then we can either repeat the FNA after 3 months, or we can do the diagnostic surgery, or we at the same time for in the non surgical method, we can perform the BRAF mutation just to supplement the risk assessment. And BRAF mutation can be if the BRAF mutation is positive, then there's a high chance that the nodule would be cancerous and surgery would be indicated in these patients. Diagnostic surgical excision is the long-established standard of care for the management of follicular neoplasm or SFN cytology. So if the molecular testing is either not performed or inconclusive, surgical excision may be considered for the removal and definitive diagnosis of follicular neoplasm thyroid nodule. So in case if the cytology is reported as a suspicious for the papillary carcinoma, surgical management should be similar to those of the malignant cytology, depending on the clinical risk factors, sonographic features, patient preference, and possible results of the mutational testing. After consideration of the clinical and sonographic features, mutational testing for the BRAF or the 7-gene mutation may be considered in nodules with the suspicious of the papillary carcinoma cytology. FDG PET is not routinely recommended for the evaluation of the thyroid nodules with indeterminate cytology. And when surgery is considered for patients with a solitary, cytologically indeterminate nodule, thyroid lobectomy is the recommended initial approach. So because there's an increased risk of malignancy, total thyroidectomy may be performed in patients with indeterminate nodules that are cytologically suspicious for the malignancy. Like if the FNA is suspicious for the malignancy, if the molecular mutations are positive for the BRAF, and in the ultrasound, there is suspicion, ultrasound findings are suspicions for the high-grade lesions, or in the ultrasound, if it is greater than 4 centimeter, if there's a history of familial thyroid cancer, if there is a history of radiation therapy in the past, and if the patient basically wants to get the surgery done, and if there are multiple comorbidities, or if there's a bilateral nodular disease. In these scenarios, it might be total thyroidectomy may be a better choice instead of doing the lobectomy. So in case of multinodules, TSH is done. If it is low, then TSH thyroid scan should be done. If it is normal, we should get the ultrasound. And if the TSH is high, then we should see if there are any cold nodules. And if there's any cold nodule, then it should be biopsied. So patient with the multiple thyroid nodules greater than 1 centimeter should be evaluated in the same fashion as patient with the solitary nodule greater than 1 centimeter, with the exception that each nodule that is greater than 1 centimeter carries an independent risk of malignancy, and therefore multiple nodules may require FNA. When multiple nodules greater than 1 centimeter are present, FNA should be performed preferentially based upon the nodule sonographic pattern, irrespective of the respective size cutoff. In none other, the nodule has the high or moderate suspicion sonographic pattern, and multiple sonographically similar, very low or low suspicious pattern nodules coalesce with no intervening normal parenchyma. The likelihood of malignancy is low, and it is reasonable to aspirate the largest nodule greater than 2 centimeter and continue surveillance without FNA. A low normal TSH, as we discussed, may indicate any thyroid pathology, and thyroid scan may be needed in these patients. So what are the best methods for the long-term follow-up of patients with thyroid nodule? Given the low false negative rate of ultrasound-guided FNA cytology and the higher rate of missed malignancies, the follow-up of thyroid nodules with benign cytology should be determined by the risk stratification based on the ultrasound pattern. Nodules with the high suspicion ultrasonographic pattern, repeat ultrasound and ultrasound-guided FNA should be done within 12 months. So these are the scenarios when there is a high suspicion on the ultrasound, but the FNA which is done came out to be negative. So how we should proceed? So if the nodules has a high suspicion for the ultrasonographic pattern, and the FNA came out to be negative, in that case, the ultrasound and ultrasound guided FNA should be repeated within 12 months. Nodules with low to intermediate suspicion ultrasound pattern, repeat the ultrasound at 12 to 24 months. If sonographic evidence of growth, that is 20% increase in at least two nodule dimension with a minimal increase of 2 millimeter, or more than a 50% change in the volume, or the development of new suspicious sonographic features, the FNA should be repeated, or observation continued with ultrasound with repeat FNA in case of the continued growth. So just to simplify, in case of intermediate suspicion, we should repeat the ultrasound in one to 2 years. And if there is increase in the size of the nodule or volume of the nodule, the size greater than 20% and volume greater than 50%, then FNA should be repeated in these patients. So nodules with very low suspicion ultrasonographic pattern, the utility of ultrasound surveillance and assessment of nodule as an indicator for the repeat FNA to detect a malignancy is limited. If ultrasonography is repeated, it should be greater than after 2 years. So the follow-up of nodules who do not meet FNA criteria. Nodules may be detected on the ultrasound that do not meet the FNA at the initial imaging. The strategy for the sonographic follow-up of these nodules could be based on the nodule sonographic pattern. Nodules with the high suspicion repeat the ultrasound in 6 to 12 months, and nodules with low to intermediate suspicion, we should repeat the ultrasound in 12 to 24 months, and nodules greater than 1 centimeter with low suspicion or pure cystic. The utility of the time interval of surveillance ultrasound for the risk of malignancy is not known. If ultrasound is repeated, it should be after 2 years. Routine TSH separation for the benign thyroid nodule is not recommended, and individual patients with benign solid or mostly solid nodules should have an adequate iodine intake. The daily intake is around 150 microgram per day of the iodine is recommended. Surgery may be considered for the growing nodule that are benign after the repeat FNA. If they are large, greater than 4 centimeter, causing compression or structural symptoms, then surgery would be a better choice. Patients with growing nodules that are benign after the FNA should be regularly monitored. Most asymptomatic nodules demonstrating modest growth should be followed without intervention. Recurrent cystic nodules with benign cytology should be considered for the surgical removal or percutaneous ethanol injection based on the compressive symptoms and cosmetic concern. Asymptomatic cystic nodules may be followed conservatively. So if there's a purely cystic lesion, then we can aspirate for up to 3 times. And again, if that recurs, then surgery would be a better choice. If any of the clinically relevant thyroid nodules should be performed in euthyroid and hypothyroid pregnant women. So papillary thyroid cancer discovered by cytology in early pregnancy should be monitored sonographically. If it grows substantially before 24 weeks of gestation, or if ultrasound reveals cervical lymph nodes that are suspicious for the metastatic disease, surgery should be considered during surgery. If the disease remains stable by mid-gestation, then it is or it is diagnosed in the second half of pregnancy, surgery may be deferred until after delivery.